Every human cell requires glucose to function, and the distribution of that fuel relies entirely on the precise metabolic machinery of the pancreas. When that machinery fails, the result is diabetes mellitus. Type 1 accounts for only 5 to 10% of all diabetes cases, making it a distinctly minority presentation of the disease. Patients with type 1 typically present with a sharp, aggressive onset of symptoms. They arrive in clinical settings suffering from extreme thirst, frequent urination, and severe fatigue, often appearing as though they fell violently ill overnight. But this sudden clinical presentation is an illusion. The acute symptoms are actually the final end-stage result of a silent, prolonged autoimmune progression. The physical signs of the disease only become visible to the patient long after their own internal immune defenses have systematically dismantled their metabolic infrastructure. The specific battlefield for this disease is located deep within the pancreas, inside microscopic clusters called the islets of Langerhans. The pink-stained area shown here isolates the insulin-producing beta cells from the surrounding acinar tissue. Under normal conditions, these beta cells serve as the exclusive manufacturers of the body's insulin, the signaling protein that facilitates cellular glucose uptake across the body's major tissues. In type 1 diabetes, an invading wave of CD4-positive T cells infiltrates these islets. The immune system identifies the beta cells as foreign and actively destroys the very factories required for glucose transport. This microscopic warfare continues undetected for months or even years. The clinical symptoms of diabetes do not trigger until an overwhelming 70 to 80% of the total beta cell mass is entirely annihilated. The defining characteristic of type 1 diabetes, absolute insulin deficiency, is a slow physical erosion that eventually crosses a biological point of no return. We plot beta cell mass against time. A healthy baseline starts perfectly stable at 100%. The path towards destruction begins with genetic vulnerability deeply encoded in specific human leukocyte antigen alleles, primarily HLA-DR4, followed by HLA-DR3. This genetic risk is heritable. If both parents have type 1 diabetes, offspring carry an approximate 40% risk. If one identical twin develops the disease, the unaffected twin faces a 30 to 50% risk. However, the identical twin data proves a crucial pathological point. Genetics alone are insufficient to cause the disease. An external environmental trigger is strictly required to activate the immune cascade. Viral infections are the primary suspects for this trigger. Congenital rubella infection, for instance, is definitively linked to a sharply increased risk of developing the disorder. Other viral links are highly complex. Studies on enteroviruses show mixed results, indicating they might play a paradoxical role, simultaneously capable of protecting against the disease or acting as the catalyst for susceptibility. While the HLA alleles establish the necessary biological foundation for the disease, the actual onset of beta cell decline requires an external viral catalyst to convert genetic risk into active autoimmune destruction. Once the viral trigger activates the genetic susceptibility, the body launches a CD4-positive T-cell-mediated autoimmune response directly against its own pancreatic islets. As the T cells dismantle the beta cells, the targeted immune attack forces the body to shed measurable byproducts into the bloodstream. These take the form of specific autoantibodies, namely anti-glutamic acid decarboxylase, or anti-GAD, and anti-islet cell cytoplasmic antibodies. These markers are highly prevalent, found in 70 to 90% of type 1 diabetics. For an asymptomatic patient, the mere presence of these autoantibodies indicates a 50% risk of developing clinical diabetes over the next 5 years. This prolonged 5-year predictive window stands in stark contrast to the sheer speed and efficiency of the immune system's localized destruction once the attack is fully mobilized. The supposedly silent phase of type 1 diabetes is projecting clear molecular warning signs, provided physicians test for the exact autoantibodies generated by the active destruction. As the destruction progresses, the pancreas loses its ability to react to immediate biological demands. The final warning sign is the loss of the first phase insulin response, the rapid surge of insulin that normally begins within 2 minutes of eating and lasts for 10 to 15 minutes.
Losing this postprandial insulin response indicates significant impending beta cell destruction, guaranteeing a 100% risk of full clinical onset within exactly 2 years. Finally, the beta cell mass crashes through the 70 to 80% destruction threshold, entering absolute insulin deficiency.
Without insulin to process glucose, sugar builds rapidly in the blood, triggering the classic triad of hyperglycemia: polyuria, meaning excessive urination; polydipsia, excessive thirst; and polyphagia, excessive hunger. The metabolic disruption is so severe that 1/3 of all patients first discover their condition by entering diabetic ketoacidosis, a life-threatening physiological crisis. The phenotypic presentation is highly specific. Patients are typically under 50 years of age and present with a body mass index below 25. Because the body is physically starving at a cellular level, despite high blood sugar, it begins burning through its own fat and muscle. Rapid weight loss is the cardinal physical feature of absolute insulin deficiency. This metric completely overrides BMI expectations. Rapid weight loss serves as an immediate indicator of type 1 diabetes, even if the patient is severely obese, mandating immediate treatment with insulin. The classic sudden phenotype of a type 1 patient is merely the physiological wreckage left behind once their internal insulin production falls below the 70% survival line. Diagnosing diabetes requires clear blood glucose metrics: a fasting plasma glucose at or above 126 milligrams per deciliter, an A1C of 6.5% or higher, or a symptomatic random glucose reading above 200. However, overlapping phenotypes can obscure the underlying cause. 10% of adults originally classified as having type 2 diabetes actually harbor GAD or ICA autoantibodies, pointing to hidden autoimmune destruction rather than simple insulin resistance. To definitively prove absolute insulin deficiency, physicians cannot rely solely on blood sugar. The pancreas synthesizes insulin by cleaving a precursor called proinsulin into 2 equal parts: an active insulin molecule and an inert C-peptide molecule. Created in a strict 1-to-1 ratio, measuring C-peptide serves as a perfect proxy for internal insulin production. High C-peptide levels indicate hyperinsulinemia and insulin resistance, characteristic of type 2 diabetes. Conversely, strictly low or completely absent C-peptide definitively proves absolute insulin deficiency, confirming type 1. C-peptide acts as the ultimate molecular tiebreaker, cutting through confusing clinical presentations to reveal exactly what is happening inside the patient's pancreas. The genetic vulnerability that drives this disease rarely isolates its attack to the pancreas alone. The faulty immune response extends throughout the body. Type 1 diabetes frequently clusters with other distinct autoimmune conditions, notably Hashimoto thyroiditis and celiac disease and primary adrenal insufficiency. If the patient's missing insulin is not perfectly managed, sustained hyperglycemia generates severe, long-term systemic damage. This includes microvascular complications like retinopathy, nephropathy, and neuropathy, alongside macrovascular threats like coronary and peripheral artery disease. The destruction of the beta cells is total and permanent. The body can no longer sustain its own life independently. Survival relies entirely on the continuous administration of exogenous insulin, outsourcing the biological function of a missing organ to modern medicine. The persistent need for exogenous intervention reflects the reality of type 1 diabetes, a permanent state of metabolic failure resulting from a targeted, irreversible autoimmune collapse.